Welcome, everyone. Thank you so much for joining us for the third session of Ethics for UBC, where we will focus on ethics in health. I am Quinn Boyle, and I will be your moderator today. I am a doctoral student at Neuroethics Canada with an interest in the ethical considerations of the development and implementation of novel and innovative health interventions. I would like to first thank the President's Office for supporting this important initiative, as well as the hardworking members of the organizing committee, Dr. Judith Hall, Dr. Judy Illis, Dr. Paul VanDonkler, Louise Harding, Marianne Bicani, and Anna Nectarline. Just a quick reminder that this session will be recorded, and in a moment, I will hand the mic to Dr. Michael Allard to introduce the session. Dr. Allard is Vice Dean of Health Engagement and Professor in Pathology and Laboratory Medicine in the UBC Faculty of Medicine. He is also a cardiovascular pathologist at St. Paul's Hospital in Vancouver. Dr. Allard obtained both his Bachelor's of Science and his MD at UBC, where he undertook postgraduate clinical training and postdoctoral research. He pursued further cardiovascular research training at the University of Alabama, Birmingham. Dr. Allard, over to you.
Thank you so much, Quinn. Hello, everybody. It's really a pleasure to be here to open up this really important session. And I want to thank you all for joining the discussion on ethics in health. To begin with, though, I would like to acknowledge that the UBC Vancouver academic campus is situated on the traditional unceded territory of the Musqueam. And the UBC Okanagan campus is situated on the territory of the Syilx Okanagan Nation. And as members participating today in the audience, I'd like to acknowledge that they may be joining from other territories, and respectfully acknowledge that. Myself, I'm coming from our family home, and it's situated on the traditional unceded territory of the Musqueam, Squamish, and Tsleil-Waututh people. I've had the privilege of living here most of my life, raised a family, and I'm thankful for that opportunity. So Ethics in Health is the fourth installation in a series called Ethics for Health. It's a 5-part series of panel discussions, which aims to explore and strengthen ethics, scholarship, and education across our Vancouver and Okanagan campuses. The discussions are intended for you, the audience of students, faculty, researchers, and alumni, to learn about current landscape of ethics at our university and opportunities to become more involved. Today, our really exceptional group of panelists will share their insights and experiences with ethics across a variety of disciplines spanning kinesiology and the exercise sciences, neuroethics, and medicine. And with that, I'll now pass that back to our moderator for today, Quinn Boyle, to introduce our panelists and kickstart the event. Thanks so much for joining.
Thank you, Dr. Allard. As an overview, this session will begin with 40 minutes of roundtable discussion amongst the panelists, followed by a period of 10 minutes, at which point the panelists will address general Q&A from you, our key audience members. Following this Q&A session, our panelists will be given a final prompt before the event concludes at about 1 p.m. If you have further questions and would like to continue the conversation in a small group setting, you are invited to join a behind-the-scenes breakout room with a panelist of your choice from 1 to about 1:15 p.m. You're encouraged to stick around and attend those breakout groups to ask any questions we maybe didn't get to during the Q&A, or something that comes up for you near the end. And now to introduce our panelists. Dr. Judy Illis is Distinguished University Scholar and Distinguished University Professor in Neuroethics in Neurology at UBC. As a pioneer in the field of neuroethics, she has made groundbreaking contributions to the ethical, social, and policy changes at the intersection of biomedical ethics and neuroscience. Dr. Ellis provides national and international leadership in her field and was appointed to the Order of Canada in 2017. Next, Dr. Paul VanDonkler is a professor in the School of Health and Exercise Sciences and Associate Vice Principal Research at UBC Okanagan. His research focuses on better understanding traumatic brain injury, or TBI, due to sports concussion or intimate partner violence. For the research on intimate partner violence, an integrated knowledge translation approach is used with the goal of co-designing and creating TBI-informed tools and resources for frontline staff working at community organizations supporting survivors. Next is Dr. Anita Palibu, who is a professor and Eric W. Hammer Chair, Department of Medicine at UBC and Providence Healthcare. She is a scientist with the Center for Health Evaluation and Outcome Sciences, and her research area falls under the broad umbrella of urban health research. Dr. Palibu is a general internal medicine specialist and practices with clinical trainees on the clinical teaching unit at St. Paul's Hospital. She is also an associate editor for the Annals of Internal Medicine. Last but not least, Dr. Heather Gainforth is an ICORD principal investigator, associate professor at UBC Okanagan, and a Michael Smith Foundation for Health Research scholar. Dr. Gainforth's research program aims to investigate how evidence-based behavior change research is applied in the real world and to advance the science and practice of integrated knowledge translation. Dr. Gainforth leads the SSHRC-funded research partnership that co-developed the first integrated knowledge translation guiding principles for conducting spinal cord injury research in partnership. So today, our star-studded lineup of panelists will be presented with 3 guiding questions for our discussion. To allow for enough time for each person to speak, I'll ask each of you to please limit all of your answers to about 90 seconds. I'm going to start by asking you to tell us about your area of interest and about others who share it at both campuses, UBC Vancouver and UBCO, as well as any opportunities for students to be involved. So in the same order I introduced you, I will start with Dr. Ellis.
Quinn, thank you so much for that preamble and introduction, and also Dr. Allard, thank you so much for joining us and being here with us today. This is a big audience for this 4th session of Ethics for UBC. I'm enormously grateful for everyone for joining us. I want to thank personally the organizing group who's worked with us to make this series happen, and also a special thanks to Anna Nectarline and Marianne Bakani for the heavy lifting in making this series possible. So in 90 seconds, who are we? Neuroethics Canada is a program within the Division of Neurology in the Department of Medicine. We were established in 2007 as a national research resource in biomedicine for the brain writ large. We have 2 core sites within our core programs, one on UBC campus in the Kerner Pavilion and one at BC Children's Hospital. We also have a formal remote site now at the University of Manitoba in Winnipeg and an informal remote site at Sunnybrook Hospital in Toronto. All told, currently we're about 35 active faculty, investigators, researchers, students, trainees, med students, and visiting scholars, an amazing cohort of people. And our collaborations span both Vancouver campuses from medicine and neuroscience, population public health, interdisciplinary studies, and on, arts and law, engineering, and also collaborations with Dr. VanDonkle at UBCO. So our daily focus across all sites is on the ethical, legal, and social implications for neuroscience discovery, translation, and commercialization where it's appropriate. So we think about the ethics challenges and concerns and promises for a wide range of advances in the brain that span the lifespan for people at home, in the classroom, in the workplace, in the healthcare environment, and in society. Since COVID, our writ has expanded to have a bit wider focus with special considerations for vulnerable and marginalized populations affected with brain and mental health disorders, among others. We have focused a lot and made a lot of commentary on human rights and justice and so forth. We also throughout have had a special focus on meanings and knowledge about brain and mind with learning from Indigenous and other populations with cultural backgrounds from different backgrounds that are different from European and Western ones. Very specifically at BC Children's Hospital under Dr. Robiard's leadership, you heard from her a couple of months ago. Her wonderful group is focused on technology, AI, and assistive robotics for children and older people, this sort of intergenerational bridging specifically. At the Vancouver campus, we're heavily focused on the ethics of invasive and non-invasive neuromodulatory and neuroimaging technologies for disorders such as pediatric epilepsy. That's in collaboration with our colleagues in Winnipeg and Toronto. Opioid use disorders, regulatory issues around patents and IP and intersections with open science, And newly, or as a recurring theme for us on spinal cord injury repair, we provide provincial and national leadership through the Canadian Brain Research Strategy, our leadership in a developing national body for bioethics for Canada, and also through global leadership through the International Brain Initiative. I really want to thank everyone who works with us today and in the past. We have easily over the past 20 years, 250 people who have worked with us through our base at UBC, and I want to thank them and those who support us. And the full story about us you can see at neuroethicscanada.ca, and we've just published a global impact report, and you're welcome to download it and learn more about us. So that's my 90 seconds plus, probably. Quinn, thank you. Back to you.
Thank you, Dr. Ellis. I will pass it right on over to Dr. VanDonkler.
Thanks, Quinn, and thanks, Judy and the rest of the organizing committee for putting together these panels. I think they've been wonderful, and really looking forward to today. So, as Quinn mentioned, my area of interest is traumatic brain injury, and I spent the first 20 or so years of my research career working in sport-related concussion, and which is a vital and expanding area of research on brain injury for sure. And then I had midlife things going on. I was divorced, and I was on an online dating site, Tinder, if you must know, and I swiped right, and I met my partner, who is named Karen Mason. And at the time, she was the executive director of the Kelowna Women's Shelter. And shortly after we started dating, she came across an article that was talking about the intersection between intimate partner violence and brain injury. And she immediately sent it to me and said, why are you looking at athletes? We need to help all these women who are experiencing intimate partner violence. And that opened up a whole range of questions around not just, trying to objectively determine the extent and the severity of brain injuries in people who've experienced intimate partner violence, but much broader questions around what do we do with this information? How do we help get that information out into the community, into different sectors that provide support and services for people who've experienced intimate partner violence? And that's where the interactions with Judy and her group, and actually it's Quinn was a master's student with me and is now doing his PhD with Judy, really drilled down on a specific question related to how we use information related to brain injury in the context of intimate partner violence, specifically with respect to criminal justice and ethical questions related to court proceedings. And I'll talk a little bit about that in the subsequent interactions. But the field of brain injury has quite a few faculty on both campuses who are either directly or indirectly involved. There's a number of faculty at the Center for Brain Health who do great work around brain injury. I guess a similar area of research in marginalized populations with brain injury is the hotel study that's led by Bill Honer and Will Panenka. And that's looking at the incidence and effects of brain injury in people who live in the downtown east side and are marginally housed. And so, extending brain injury research beyond the context of sports concussion and military personnel and people who have accidents to folks who are, maybe haven't been, have had research done with them and for them is definitely a passion of mine, and it intersects with these ethical issues in a major way. So I'll talk more about it in subsequent pieces.
Such important work, Dr. VanDonkler. Thank you. Next, I'll hand the mic to Dr. Palibu.
Thank you so much, and I'm grateful to be here at this session with all of you. So I came to Vancouver in 1996, and at that time, unfortunately, the HIV epidemic was rampant among people who use injection drugs, and that became the area of focus of research that I participated with participants in the Vancouver Injection Drug User Study, and my focus was around healthcare use and healthcare costs. It changed over time, looking at access and adherence to antiretroviral therapy and what were the factors that led to better health outcomes. And, one thing that consistently was not a favorable thing was continuing substance use. It was a barrier to care. It was a barrier to adhering to treatment and having successful outcomes. And we also looked at addiction treatments and how that impacted people's outcomes. Another variable that kept coming up over and over again was also housing and unstable housing, and that portended poor outcomes. So over time, my research has focused more on social determinants of health, particularly housing, and I've collaborated with people across the country looking at cohort studies, and I was part of the at-home, the Housing First trial that was in 5 cities, and Vancouver was one of them. So that when we talk about urban health, it really refers to sort of the social and physical environments that people live in, which are really what determines people's health and how they experience disease. And when we think about people who experience homelessness, in our studies and in other studies, at least 1/3 report having a traumatic brain injury is defined by losing consciousness, concussion, really interferes for some people with their executive function. And if you don't have that wraparound family support, if you are low income, if you are marginal, in that way in our society, you can see how they slip through the cracks and are so vulnerable to losing their housing, losing their employment. So wearing my other hat as a clinician, I take care of patients at St. Paul's Hospital, many of whom have experienced poverty and marginalization in our society. And there are many, many ethical issues that come up that we deal with in caring for people. And so I'm happy to speak to that. So a lot of these issues are also happening at the Southern Medical Campus, at the medical school, and these issues are encountered everywhere. I just came back from Prince George, and Northern Health and the issues of health equity and access to care is huge on my mind after that visit. And particularly for people who are Indigenous and, the layers and layers of trauma that they experience, and then having to come into hospital and having to leave their community and feeling outside of feeling safe and institutionalized has huge impacts. So we're all learning how we can be better at delivering care to a very diverse patient population. So I'll stop there. Thank you.
Thank you, Dr. Palibu. Always really interesting to hear your perspective as both a researcher and a clinician seeing this day to day. And now on to Dr. Gainforth.
Thanks so much, Quinn, and thank you to everyone for inviting me here today. I'm really excited to learn with you all. So my background, I'm initially a behavioral scientist. I'm interested in why people do what they do, and how we can develop tools, resources, and interventions to help them change their behavior when they want to. I'm particularly interested in designing tools, resources, and interventions in partnership, and doing that for equity deserving groups and with equity deserving groups, with a particular interest in working with people with disabilities, and specifically people with spinal cord injury. So who do I work with at UBC because of those interests? I'm based in the Center for Health Behavior Change here at UBC Okanagan campus. So I work a lot with Dr. Mary Jung and Dr. Kathleen Martin-Guinness. But then I'm also an ICORD principal investigator, so the International Collaboration on Repair Discoveries, working with scientists that are interested in the area of spinal cord injury in particular. And all of the work I do pretty much is partnered. So I work with people that will directly use my research, people with decision-making power and without decision-making power, to design interventions that best support them, and that are relevant, useful, and usable to them. And I always thought that I would be a behavioral scientist at my core, taking a partnered approach. But over time, my partnered approach has become the thing that is of most interest. And I'll probably talk a lot more about that, Quinn, but I've now become a researcher around advancing the practice and the science of partnered research and integrated knowledge translation. So I work in the IKT Research Network. That's a Canadian network across Canada led by Dr. Ian Graham and Anita Kathari. With that, I've essentially become a researcher who does research on researchers doing partnered research. And it's kind of a really fun opportunity. And if you're interested in looking at the way you do your science and the principles in which you partner, there's lots of fun ways for students to get involved. So hopefully we'll talk a little bit more about that too. Thanks.
Thank you, Dr. Gainforth. Always, reflexivity in science, very, very important, thinking about how we do it and how we should move forward. And by logical extension of this conversation and outlining everyone's areas of interest, with this next prompt, I will ask each of you to briefly identify the cutting edge ethical issues in your area of interest, or if you prefer, can you give us an example of a specific ethical dilemma that you have encountered and feel is significant, and maybe how you addressed it? This time I will start with Dr. VanDonkler.
All right, awesome. So I guess I want to go a little bit into actually Quinn's thesis. So if I get anything wrong, Quinn, maybe you can correct me. But the idea here was, we're interested in this intersection between intimate partner violence and brain injury, and I come at it from a kind of a clinical mindset where our goal is to help people get over the fact and help them in terms of providing supports. And so it's kind of a healthcare supportive sort of mindset. And kind of the assumption is, well, if we determine that someone's had a brain injury from intimate partner violence, then maybe we can use that, or they can advocate for themselves to seek out supports around improving their function related to that brain injury. That's a whole other conversation around whether there are sufficient supports, whether there's enough knowledge and awareness of brain injury in folks who provide supports for people with who've experienced IPV. But then Quinn came along and said, well, what about how else this information could be used? Could it be potentially weaponized, specifically in the context of the criminal justice system? And my background is in clinical neuroscience, so my expertise kind of ends quite a ways away from the ethics of the criminal justice system. And so we had the good fortune of having Judy Ellis on Quinn's committee, as well as a colleague from UBCO, Dr. Dina Simonetto, who's a sociologist here, who's interested in kind of the social cultural components of brain injury in a number of different populations. And so the ethical kind of dilemma that was the core of Quinn's thesis was, can a brain injury diagnosis in a woman who's experienced intimate partner violence actually be used against her in family law proceedings? And because this intersection between intimate partner violence and brain injury is so new as a concept, as something that people would think to do research on, how that information that is generated in some of the kind of science-based research that we do may be potentially used in other settings was new, right? And so Quinn, this thesis basically looked at the potential for a brain injury diagnosis to be used against women who've experienced intimate partner violence. And sadly, but informatively, the kind of bottom line of his thesis was that yes, with the way the current criminal justice system and family law system is set up, the potential is there for a brain injury diagnosis to be weaponized in the court of law. And so it leads to all these kind of other things that need to be done in terms of some of the things that Heather talked around integrated knowledge translation. So working with lawyers, judges, other folks who are involved in the legal system to raise knowledge and awareness around brain injury and intimate partner violence. So we have a long ways to go, and Quinn's thesis was, very much the very first step in this regard. So really opened my eyes to how the information we generate in the lab can actually get out there into the world and potentially be misused by bad actors.
Thank you, Dr. VanDonkler, for the shout outs. But now I'll pass it over to Dr. Palibu, please.
Thank you. So I think the one area that we always struggle with is when it's the tension between, the principle of beneficence, trying to do good for the patient, and patient autonomy at times, when we want to we recommend something based on best evidence, based on their circumstances and our diagnosis and the recommended treatment, and the patient doesn't really want to do that, and we worry about their outcome, and then sometimes we worry about their capacity because of their understanding. Are they capable? So that's the other thing of assessing, is capacity. And sometimes we have, because a lot of people that we look after do have mental health concerns and issues, we try to make sure we're doing our due diligence to ensure that they have capacity, and most of the time they do. And people can make decisions that we wish they didn't make for their own health. People will do patient-initiated discharges, or we call it sometimes going against medical advice. They will leave prior to their treatment being completed, and this happens. And it's a hard lesson for learners and the team, because it's not illegal to make what we think are bad decisions. But sometimes what we have to do is understand where people are coming from and the reasons. And so that's why it's very important in providing care to be as relational as possible. And that has been challenging with COVID, because we're often, layered in a gown with a mask, with a screen, with goggles. And it's hard to make that human connection that you would otherwise. So I would say that is one of the big challenges that we have, is understanding where people are coming from, what their needs are, and how do we mitigate harm from decisions which they feel is in their best interest at that point in time, and not to cause harm in the relationship, so that if they are getting worse, that they will feel comfortable to come back. So that is something that is a tension for us between trying to do good, what we think is good for them, and balancing their autonomy and their own needs and their own priorities. So I'll stop there. Thank you.
Thank you, Dr. Palibu. I think you eloquently summed up the nuance of ethics and providing ethical care. Next, I'll hand the mic to Dr. Gainforth.
I have to build on Anita, that piece of relationality, I think, fits really well with my key thing that I think about when I'm thinking about ethics and my work. So I think I'll tell you a story of, I was very initially in my faculty position in my first year as a faculty member, and I was asked to come and evaluate a conference that aimed to close the gap between research and practice in the area of spinal cord injury. And there were a number of very esteemed speakers and partners and researchers from all different disciplines and from across North America and around the world. And at the end of the conference, I was sitting with a number of community organizations that I'd worked with to develop behavior change interventions, things from physical activity. Now we're looking at smoking and peer mentorship and all these different things. And we were talking about this gap between research and practice. And a number of the individuals with spinal cord injury said to me, well, why don't researchers take the approach that you take? Well, if they would just partner with us, if they would just work with us, the research would be more relevant. It would be more applicable. It would be more useful. And I think it's a very relational question. And I said, oh, well, if we did that, not everyone does their research that way. You would have to change the entire spinal cord injury research system. And they said, so? And I felt a little sick. And then the key statement that was said back to me was, maybe instead of changing our behaviors to make the lives of people with spinal cord injury better, could you change the researchers' behaviors? If you're such a great behavioral scientist, apply your science and change the researchers. And I felt more sick. But I went away and thought about that, and thought about, how do I put my behavioral scientist hat on and think about, what does it mean to do partnered research? And what they really talked to me about was not just that researchers won't partner, but when they do partner, they do it in a way that's very tokenistic. So we love to submit a grant and put a person with lived experience on that grant to show partnership, but that person has no decision-making power. They don't necessarily have autonomy. There's not shared decision-making in that. And so it creates an experience of tokenism. It creates an experience of feeling not valued, not engaged. And I would argue that it actually not only damages that partnership, but it damages all of science. And so we started to think about, what does it mean to meaningfully engage? What are the behaviors? And also, what does tokenism look like in spinal cord injury research? And we established a partnership to actually say, how do we transform the spinal cord injury research system so that we stop tokenism and we meaningfully engage when we have researchers and research users together? And since the start of my faculty position, that's been the main goal of my research program, in addition to my behavior change pieces, is transforming a system, not just the researchers, but research users and funders. And what I really think about as a partnered researcher is the rightfulness and the wrongfulness of my actions. When I'm partnering with people that use my research, what does it mean to be acting with integrity? What does it mean to actually do meaningful research? And that's where we started. We started with principles of partnered research that are based in evidence, and I'll put a link to those. But really changing not just how we think about reflecting on our science as, does it meet the standards of the ethical review board, but does it meet the standards of your own values as a partnered researcher, as a scientist that's working with people with lived experience? I'll leave it there.
Thank you, Dr. Gainforth. I think that story will resonate with everyone in the room, faculty and student alike. It was really great. And now rounding up this prompt, Dr. Ellis, please.
All right, thank you. So I'm going to give 3 quick examples of, I think, really passionate ethical challenges that we've had in neuroethics. And it's going to be from the area of research ethics, research and clinical or possible clinical translation. And so the research ethics piece really builds on what Dr. Palibu and Dr. Gainforth have shared in terms of some of the ethical challenges of collaborative and co-creative knowledge creation and discovery. And we had the privilege of working with the Tahltan First Nation. It's a nation in northern BC, who many of whom have the PS1 gene that puts them at very high risk for early onset Alzheimer's disease. When we started working with the nation, we started going up and doing health days and generating grant proposals and ideas together and research questions together. We were faced with the challenge of attribution versus anonymity. And the nation at the time really wanted to retain their anonymity so as not to be stigmatized for this disorder that was penetrating their community. But at the same time, attribution was essential in order for them to gain the benefits of the research that we were co-creating together. We had to really find a way, a middle spot where they could receive attribution in the grant proposals, be identified on publications, in our training of members of the community, while really paying attention to and mitigating the potential stigma that they might have experienced in engaging this work with us. So that was one. In the area of research, a timeless problem, it seems to be, is what happens if you are a person presumably healthy and you are recruited to and enroll in a brain imaging study, and students or PhD researchers detect something in your brain that might be clinically significant. The majority of people would say, well, I would want to know. But on the other hand, this is a research study conducted by non-physicians, and there's been a lot of debate, and it now continues really into its 20th year around who should know, who has the right to know, who has the right not to know, who should tell, how should that telling happen, and on and on. And we continue to work in that space. And my third example is really in the area of possible clinical translation of neurotechnology. And this is where brain-computer interfaces today are enabling researchers and eventually likely clinicians to, I'm going to say, read or have available to them signals from the brain that may suggest that somebody in a disordered state of consciousness is actually more conscious than clinical exam would suggest, or even to communicate through technology when a person doesn't have verbal capacities anymore. And so we now have very complex interfaces with the brain, both in and on the brain, that are generating signals. And to what extent can we use those signals actually to help a person support their autonomy and respect them? I would suggest in the area of pain, those signals would be vital, but we're also dealing with whether those signals should be used to allow somebody to ask for medical aid in dying, refuse medication, and really, irreversible decision-making. And so those are the three examples I wanted to bring to the table this afternoon, actually, at this point.
Thank you, Dr. Ellis. Our last prepared prompt for today, how can we facilitate better, more ethical practices in your area of interest? And this time I will start with Dr. Palibu.
Well, I think relationship is probably the foundation, and it's about caring. And when I talk about caring, Francis Peabody said the secret to caring for patients is actually caring for patients. And so breaking that down further is what are the virtues underneath it, and then what are the ethical principles that ladder up to it. I think our challenge in the world that we're in is we are under so much pressure to deal with a lot of unmet need that's in our society that ends up manifesting in health and disease issues, that we don't have sufficient primary care, and then people get sick and come to the hospital. And I feel like our healthcare system is really like a disease management system where the challenge for us is everything has become so transactional. And again, in order to foster well-being and connection, we have to become more relational. So I think there's fundamental issues around our whole system. So it's not just how I think, it's like, what is the system that we're living in, and what does it value, and how does it create the relationships that we have or lack of? So I feel like that is the biggest challenge that we're dealing with, is when a system is under pressure, I think we just go to the lowest common denominator in performing our work. And that is a challenge for our health system, is to maintain the caring for people and one another, right? Because as you know, with the COVID pandemic, burnout amongst all healthcare providers is very, very high. And it was already high prior to the pandemic, and I think it's just gotten worse. So it's not just the well-being of the patients that we're trying to take care of, it's also the providers being well enough to give the care that the people who are sick and are vulnerable really need. So I think that is the challenge going forward.
Thank you, Dr. Powell. I love your passion about injecting empathy into healthcare. It's great. Next, I'll pass it to Dr. Gainforth, please.
I keep leading off Dr. Palibu. I would actually encourage us to think about injecting empathy into research and science. I think that our first step is to understand that research is relational. I think often we think about research as this curiosity-driven thing that is unbiased and almost sometimes I don't want to use the word clinical, because we just talked about it being relational, but like sanitized almost is what I'm going to say. But I think that people matter, and that relationships matter, and that good science comes out of good relationships. And that if we could start by thinking about research from a relational aspect, whether you're doing that relationship building with a researcher or a research user. So I think the ethics of when you're working with your graduate students, when you're working with other researchers that are not you, when you're working with other research users, and having a really clear understanding of the rightfulness and the wrongfulness of your actions as a researcher in a team beyond just what the research ethics board says, but the rightfulness and wrongfulness of your actions. And that's why we have principles. But then from there, recognizing that good intentions are not enough. I think a lot of the challenges of tokenism in science, a lot of our challenges in partnered research actually come out of people having really wonderful intentions. They want to partner, but they haven't really thought about it, and or the system that they're in isn't supporting them to do it. So just like what Anita was just talking about, the system of research is often designed in a very transactional way of get the money, get the funding, get the number of publications. But instead, can we create a research system that incentivizes, that mentors, that transforms to create a generation of scientists and partnerships that are meaningful, that are not tokenistic? And that actually requires researchers to change, it requires institutions to change, it requires funders and our research users to change, and it requires all of us to hold ourselves accountable and recognize that we're going to make mistakes. So we're going to have to learn to be a bit vulnerable. We're going to have to learn how to hold ourselves accountable and apologize because we don't necessarily have all the answers, but we're trying our best to figure it out. And I think it's finding that strong back of what's okay and what's not okay in what we do, but keeping that soft, compassionate front at all times. Yeah.
Beautifully said, Dr. Gainforth. Thank you. Next, I'll hand the mic to Dr. Ilis.
So I'm going to take us in a slightly different direction, although I could not be a greater cheerleader for respect and empathy and compassion in health. But I think it also extends to all of our ethics interested programs and people across UBC on both campuses. And I reflect on the conversation that Dr. Hall and I had with President Ono when we first sort of introduced the concept of this series. And he said, how can UBC become a leading university in ethics, scholarship, and practice? And so I think being nice to each other and everyone with whom we interact is definitely number one. I think we also, more practically speaking, have to become a little bit better coordinated across our areas of discipline. So right now, so many of us pool students from each other's programs. I have students from experimental medicine, a population and public health, and I had students from sociology. But as a group of leaders and directors in ethics programs at UBC, I think we need to unsilo our programs and get together and actually think out of the box in some really big vision thinking about how we can harness the tremendous strengths of ethics expertise and scholarship and interest we have on our campuses and bring them together. And that isn't to say that we all need to become one big mushed body. I think what we need to do is retain our areas of strength, but leverage them in a much more coordinated and formal way than we're doing now. And we can do that through student teaching. We can do that through graduate fellowships. We can do that through hiring more faculty. And countless ways of implementing on both a small scale and a larger scale better ethics presence and visibility and commitment across our campuses. And I really want to give a shout out to our research ethics boards who do so much work on our behalf and are somehow siloed in this like, oh, they're only the REBs. But the service that they provide to us as researchers in enabling us to do the research that we do is tremendous, both on the behavioral side and the clinical side. And I think we need to draw them in more into the daily activities of the design and the implementation and even the dissemination of the results itself. And finally, I think we need to harness the wisdom and experience of our alum and our faculty emeriti. They've been around the block so many times, and there's so much we can learn from them and gain from them. Dr. Hall is a leader among the emeriti. I want to give her a shout out. And as an organizer of this series and of our advisory board, a tremendous force of wisdom and vision. And we need more Judy Halls. We need Judy Hall and more Judy Halls in our sphere to lead us to be what President Ono suggested is a leading university in ethics research, scholarship, and education.
Thank you, Dr. Ellis. And last but not least, on to Dr. VanDonkle.
Okay, well, let's go from the really big to maybe the really small and kind of a pragmatic example or a thought I've been having around this, which is quite often in the humanities and social sciences, when people are writing about their research, they'll include a positionality statement. And it's about the relationships, right, to the situation or the issue that they're studying. And we rarely see that in the sciences. I can't think of any paper that's about, measuring cardiovascular disease or looking at how the brain functions in different states, where a researcher or a group of researchers would put, who they are and where they're coming from in terms of their approach to that research. And I think that reflects kind of some of the things Heather were talking about. We think that in the sciences we're objective and we're just measuring in a completely unbiased way some aspect of how the human body is functioning or not functioning properly. And I think doing that simple step, whether it's included in a paper or not, will maybe open up both PIs and trainees' eyes a little bit to how they relate to the people and the topic or the issue that they're studying. And so that's something that we've talked about in our group about implementing, even though, probably half the people who are doing research on our team are doing it from an objective lab-based, I'm going to assess this thing and measure it. And I think it's really important to stop and think about, well, how does where you're coming from relate to those measurements you're making?
Awesome, thank you. I am aware of the time and I want to leave as much time for audience Q&A as possible. So very quickly in one sentence before we get to that Q&A, could you each share one resource with us, such as a book, article, or podcast? And what would it be? So I'll start with Dr. Gainforth really quickly, please.
I think my strong back, soft front might have tipped you off, but I would say Dare to Lead by Brene Brown. It's about integrity, know your values, and then live into them. She's a fantastic book, and then she also has 2 podcasts. So lots of resources there.
Awesome, thank you. And on to Dr. Illis.
I'm going to give you 2 quickly. One is The Spirit Catches You and You Fall Down by Annie Fadiman. The collision of traditional biomedicine and traditional values in treating epilepsy among a child with epilepsy in the Hmong Nation. And the second book I would recommend is Tuesdays with Maury, which is author Mitch Bloom's experience with his former sociology professor who is dying of amyotrophic lateral sclerosis. And both are very passionate and informative and wonderful reads.
Thank you. And just a quick note, everyone, we will be posting these on the Neuroethics Canada website, so don't scramble to write everything down right now. But on to Dr. VanDonkle, please.
I'm going to recommend Dr. Kate Mann, who's a philosopher at Cornell University. She's written a couple books, one of which is entitled, and it's about how male privilege hurts women. So it really is looking at the much broader question around, how society is set up and how that privileges men, that in turn leads to, in many instances, violence against women. So a really great resource. She's written a couple books that are about this topic. And I'll just put it in the chat here.
Thanks. And lastly, Dr. Palibu.
Thank you. The Immortal Life of Henrietta Lacks, whose cervical cancer cells became an immortal cell line, the HeLa line, and is written by Rebecca Skolnick. I think Rebecca Skolnick has a new novel out recently as well. This is also a movie that Oprah stars in, so you can get it in many ways to see the dramatization, because this is a nonfiction, incredibly well-researched, highly compassionate portrayal of this particular journalist looking at and becoming curious about where did these cells come from and what she uncovered, and the life of the woman whose cells have spawned so many discoveries in cancer and other diseases. It's also a story about power and privilege and racism, and it really challenges you to think about what is patient autonomy, what does do no harm mean, what does consent, truth-telling, confidentiality. It hits all of those notes in this book, and it's written with, it's not written in an impassive way. It's extremely compassionate in the writing. So I thought it was a fabulous book. I would highly recommend it. Thank you.
Thank you. And I think now is the time we will take some audience questions. So please, you can raise your hand, use the raise hand function, and you can speak aloud, or you can type them into the chat and I can read them out. If it's for a specific panelist, you can ask it specifically to them, or we can kind of give it as a general question. And remember, we do have the breakout rooms as well, so if we don't get to it, please stick around for that. Okay, I have one here. I will read it out. How do you balance truly celebrating the participation of people with lived experience with the burden of such, in particular with the limitations so that the funding agencies are putting on payment to team members?
We'll probably talk to that a little bit in terms of how we think about that with our guiding principles. So in terms of the benefit and the burden, so I'll start with that. In terms of the benefit of partnered research, often what people tell me is that partnered research takes longer. And I say, well, it depends what your end point is. Are you talking about your publication, or are you talking about impact? Because I think if you're talking about impact and making sure your research is relevant, useful, and usable, I think that it's often more efficient to do partnered research. Yes, that doesn't mean that in terms of burden, though, that it's not hard. It absolutely is hard. Relationships are hard. They take time to build trust. They take time to connect. They take time to foster, to deal with conflict. And that can be challenging, but it requires conversations and coming back to your values. In terms of, has the funding system established a system that allows us to meaningfully partner? No, not always. It depends on the funder. And I think funders really need to intentionally think about the structures of their grants and whether they actually allow for meaningful partnership and also meaningful remuneration for people's roles in partnership. I'm seeing things change. I'm seeing that talked about more often. But I actually think that's a very open, transparent conversation right now that you need to have with partners you're considering working with from the outset. This is how this grant would pay you if you want to be paid, if that makes sense for you. This is what that could look like. Does that work for you? Or do we need to apply to a different grant? Like maybe this is not the grant organization for us. Maybe we need to go somewhere different. If you go somewhere different or that grant organization doesn't work for you, I think your role as the researcher is to provide feedback and advocate for changing the system and the science. So making sure we're communicating to funders, because I think even though funders are asking for partnered research, sometimes the way those funding opportunities are set up actually pave the way for really deep tokenism instead of real meaningful engagement. So I hope that helps.
Thank you. I have another one here that I want to get to quickly. This is regarding knowledge translation from Emily. They ask, what ethical considerations should or can be made to address information overload? And I think this is especially relevant in maybe the fields of Dr. VanDonkler and Dr. Palibu, but of course, Dr. Gainforth as well.
But I have an answer.
Sorry, Dr. Ellis, of course, yeah. Anyone that wants to start us off.
So my answer is that I'm really actually more concerned with good information and evidence-based information than I am with volume of information. I think we have to really start focusing on ways to ensure that the information that's getting out to people and patients in health and healthcare in particular is evidence-based, and that it doesn't get lost in information overload and also the noise of what we've called fake news, or moderately or untrustworthy information.
Okay, I'll ask one more question and then we'll move to the breakout room. This one's for Dr. VanDonkler from our own Anna Nectar line. How can the medical system and the legal system better communicate to prevent the weaponization of medical info?
Yeah, well, I think DeSiloing is a overused term, but getting people in the same room at the right time, talking through the issues. The medical information is what it is, right? It's this objective thing that we like to think is going to be used to help people, and I think in most cases it does. And so how it gets used outside of a medical context, I think is a conversation that needs to be informed by the healthcare system, but ultimately it's the justice system that needs to think through how information or evidence is used and make sure that it's used in a fair and equitable way. And unfortunately, that in the context of family law and violence against women, it's unfair, and it isn't aligned with the principles of justice currently, and that's a sad state, right? And so I think that's the beginning of the conversation, and it's not just around violence against women. I think there are many other examples where that intersection needs to have better communication.
Beautifully said, Dr. VanDonkler. So just a reminder to everyone that if we couldn't get to your question, please bring them to the breakout groups that are about to start. But before we move to those optional behind the scenes breakout sessions, I would like to thank Dr. Michael Allard for his opening remarks, our distinguished panelists, of course, and lastly, our audience members for attending yet another great session of Ethics for UBC. The fifth and final session of Ethics for UBC focuses on ethics in environment and democracy, and is coming up on May 25th. So be sure to register that. You will receive information about the next panel, and also a very brief follow-up survey to kind of further the goals of the Ethics for UBC series. So thank you for joining so much. If you are in Vancouver, please go enjoy the sun today. Thank you very much.